I, I have this pleasure to invite Dr. Vivek Dave. Dr. Vivek Dave is my teacher and a lot of us teachers, who's a very dynamic clinician scientist from L.V. Prasad Eye Institute. And he has, to his number, more than 100 peer-reviewed publications in national and international journals. And now he's a known man from Telangana to Taiwan. Dr. Vivek Dave, the stage is yours.
Thank you, Vaibhav. I think that was a super kind international sort of an introduction. I hope I'm audible clearly.
Yes.
All right. So thank you and good morning, good afternoon, good evening, everyone from whichever part of the world you have logged in. I've been given a topic titled Penetrating Trauma with RD, Pandora's box. Now, a Pandora's box, as you know, is a metaphor in our modern language, and the proverbial phrase refers to a source of endless complications or unexpected occurrences. So what do I have in my box today? 3 cases. All 3 are related to trauma. All 3 of them will have retinal detachment. Each is a unique situation, and we will attempt to go over their management approach and see some observation and learning points. So case 1, a 40-year-old male post-corneal tear repair elsewhere 2 months before the presentation to us, was diagnosed at that place as inoperable retinal detachment, with the notes mentioning retina is incarcerated and inoperable. And the patient was then referred by a local physician to us for a second opinion. Now, this is what the eye looked like. So if you see, this was the corneal wound which was repaired, and if you can see here, few of the sutures were removed locally. This is the fundus photograph. It's not very clear, but you can see that most of the retina is attached. But right here, if you can see, the retina has a fold which sort of goes towards the wound, and this is the area which was incarcerated right anteriorly into the wound. And this patient was a phakic. So we made a diagnosis of repaired corneal tear status post penetrating injury with retinal detachment and incarcerated retina. So I go ahead, try to clear out the muck, and the first Pandora's boxes element right there in front of me. The wound was still open. Though the sutures were removed, the wound integrity was not there 100%. So I had to go ahead and repair the corneal tear first. So something which I had not prepared myself for, but then sometimes you have to do it. Then a belt was passed all around as shown, following which a vitrectomy was started, and the anterior vitreous was cleared so as to clear out the vitreous over the incarcerated retina. You can see the fold here. The retina per se was pretty lax, other than the fact that the fold was entangled in the wound right anteriorly. So you go ahead and you do a release of the retina from that wound. And now you can see that retina is pretty lax, and you are already relaxing that this is going to be a cakewalk going ahead. PFCL is being injected. Retina starts settling down. And then while I'm injecting the PFCL, the second element comes up. A small air bubble gets released from the PFCL cannula, comes anteriorly towards my left hand. I get irritated. I sort of attempt to remove it quickly, and what I get is hemorrhage. So this is what happened. My instrument got stuck in the choroid and tore it apart. So something which I felt was a trivial sort of a maneuver, but it had real big implications, and now I had lost all visualization. So I fill up PFCL again. The residual fold of the retina, I do a small radial retinotomy to release it, so that part of the retina falls back well. And now I would think I would go ahead and do a laser and then replace this with air and then silicone oil. But moment I attempt to remove the PFCL, again there is this spurt of blood. So this is a fresh hemorrhage right from the choroid, which is not allowing me to remove the PFCL at all. I made a few attempts. I waited on table to see if this clots down, but this was not to be. So I had no other option but to leave PFCL in the retina, fill up the entire eye with PFCL, do my endolaser, and then close the eye with PFCL in situ. This is how it looked like in follow-up. This is around 3 weeks down the line with PFCL in situ. Now, this in my practice is the upper limit to which I leave PFCL in the eye. So this is the point at which I decided to replace the PFCL with silicone oil. So on table, this was the eye with PFCL. You can see that the retina is well settled, no more hemorrhage. Everything has clotted down and healed well. So you go in and a simple process, aspirate out all the PFCL and then replace it with air and subsequently do a silicone oil exchange. This is what I was left with in a silicone oil filled eye. This patient is actually from a different city up north in New Delhi and is likely to follow up later for silicone oil removal. But just to demonstrate that a few things can happen in trauma. If you have a previous wound, you should be sure that you check that wound well. And once in a while, you may require to revise it. Choroidal bleeding due to instrument touch, especially in trauma where tissues are sometimes inflamed or you have a choroidal detachment or you have compromised visualization. Or in my case, sometimes when you are possibly in a bit of a hurry and you may, sort of make a wrong move, you may end up with a choroidal bleeding. If that happens, PFCL can be used as a tamponade. And as we know, PFCL can be left behind. You can always come back to fight another day and then exchange that PFCL with oil and salvage the situation. So we go to the second case, which was again a repaired corneal tear elsewhere. Also had endophthalmitis following a penetrating injury, retained intraocular foreign body, and an edematous cornea which was precluding a good posterior segment visualization. This was the presentation to us in our clinic. You can see that the corneal wound was sutured, albeit here it possibly was closed down under some amount of tension. There may have been some tissue loss. Exudates in the anterior chamber. No real great view through the cornea. And if we would have had a slit lamp slit, we would have seen that all this entire cornea in the center was highly edematous. B scan showing a lot of retained foreign bodies and also a partial PVD that was seen in the superior scan. Now, in my practice, when encountered with such a cornea which is hazy due to edema, I take an endoscopic approach because I feel that allows the cornea to have one opportunity of a natural clearance. So if you go ahead and replace it with a keratoprosthesis or a penetrating keratoplasty, you basically have not given the host cornea a chance to clear out on its own. So I go ahead endoscopically. As you see, once inside, all these exudates are very well seen, amenable to very good clearance. And then as you encounter in trauma, sometimes you may find weird things. So here I find an eyelash in between the exudates. Right at the end of the eyelash, I track down a foreign body. And as you saw in the B scan, there were multiple foreign bodies. So I move around, hunt for more of them, and actually I find multiple ones of different sizes and shapes. So foreign body has been released. So now you want to go in with a magnet and pick them out, and you're again relaxing mentally that the day is done. But unfortunately, these were non-magnetic. I take my magnet and to my dismay, none of them gets attracted to the magnet at all. So I come back in, take an ILM forceps because the routine foreign body forceps was too large for these foreign bodies. So just take an ILM forceps, spread out its prongs a bit, and you can actually make it into a foreign body forceps. I bring it up, rest it on the iris, and then from an SICS wound, remove it using a McPherson's forceps. So one foreign body out, I think I'll go back in and remove all of them. But unfortunately, the site of impact gave way. And what I see now is a bullous retinal detachment inside with a few foreign bodies still remaining to be removed. The fact that vitrectomy was adequately done helped me here. So I could put in PFCL and push back all this bullous retinal detachment adequately enough to flatten out the posterior pole at least till the equator. So now that allows me to visualize the foreign bodies again. And now I pick them up again one by one, same maneuver, bring them up, deposit them on the iris, take a McPherson, and then remove them. Go in again and repeat the same process again till each and every one of them has been removed. Once that was done, I looked out for a break. I found a horseshoe tear peripherally through which the retina was flattened first by a fluid-fluid exchange and then by extending the PFCL all across. I completed the 360-degree endolaser. This you can see now the retina is well attached, well lasered. And once this was done, the PFCL was replaced with air and then sequentially with silicone oil. This is what the eye looked like. This was around, I think, a month down the line. You can see that the cornea is beautifully cleared out. Now, if I would have done a keratoplasty here, I would have made this person a post-PK patient for life and possibly put him at a risk of graft failure. If you remember, he was a young person, so a lot of life to live with a graft in situ. The retina was well attached. Vision was not very great. It was 4/60. But if we look at the presentation with which the patient had come, I think I would take 4/60 any day. Quirkily, I think this was one small piece of hair, which possibly I did not pick up on table and is now jutting out there on the fundus photograph. So in this case, the Pandora'S items are that visualization in retinal surgery is paramount. If media is not clear, endoscopy can be a game changer. RD can occur at any time during surgery, especially after the IOFBs are removed, because the impact site may be a full thickness site. ILM forceps can be used as a modified foreign body forceps for small non-magnetic foreign bodies. They work well. And PFCL, as we know, is an important third hand on table because often these detachments, when they rise up, they are bullous because of fluid movement and the fact that the vitrectomy was complete before the detachment occurred. Now, quickly going to a third case, this is not something which we encounter unusually, but I think this has an optical learning point. So post-scleral tear repair, patient with retinal detachment and dispersed vitreous hemorrhage. Now, vitreous hemorrhage here was adherent to the crystalline lens capsule. So if you can see, I am holding this eyeball and you can see these parallel streaks of hemorrhage that are adherent to the posterior lens capsule. Now, as we induce a posterior vitreous detachment to take off the posterior hyaloid of the retina, a similar maneuver can be done even anteriorly to separate this hemorrhage, because it is in the anterior hyaloid phase, to separate this from the crystalline lens. So if you see, this is what I'm doing after having done a vitrectomy around the posterior aspect of the crystalline lens. Then I just put the cutter off, engage all of this anterior hyaloid and the hemorrhage, and pull it peripherally and backwards. So this sort of induces the opposite of a PVD and AVD, if you want to call it. So this is very safely done, and in my experience, doesn't harm the posterior lens capsule at all. So you will see the pre and post photographs of this maneuver, and notice how nicely we have been able to achieve the entire clearance of the lens. So once this was done, largely rest of the case is simple. You clear out the hemorrhage, you deal with the retinal detachment, look for the break. Now here, because I could not find the break, I have made a drainage retinotomy and then flattened out the retina. But always keep in mind that the rhigmatogenous retinal detachment that was present primarily would possibly obviously be having a break. And if you're not seeing anything, then try to examine under air, because air acts as a concave lens and it is likely to give you more visualization of the periphery. So that is what I do here. I get a good visualization of the periphery, and on slight indentation, I'm able to see the ora serrata area. And here, if you can see, I have picked up the peripheral break, which can be cryoed easily. And once cryoed, the rest of the steps in terms of replacing the air with silicone oil are standard steps. So finally, the Pandora'S item in this last case would be that post-trauma detachments can have associated vitreous hemorrhage, which can layer the posterior lens capsule. Anterior hyaloid detachment using a cutter in suction on cutter off mode is a safe maneuver for clearing this hemorrhage. Expect breaks near the ora, especially in clean-looking post-open globe injury detachments. And a fluid air exchange allows for a greater visualization of the periphery due to the concave lens effect that is induced by the air in the posterior segment. So thank you very much for all your kind hearing, and I'll be glad to take questions if any. Thank you.
Vivek, great cases. And the first one after you stitched the cornea, you still got such a good view from the fundus with that wide-angle picture. That was awesome. And I like to operate on phakic patients. And I do pretty much what you did. I avoid touching the lens by zooming it a little more, as you did. And so I kind of pull the vitreous towards the cutter so I don't go towards the lens. And so in this way, I get the vitreous down, and that's the tip. Otherwise, the surgery wouldn't go on well. You would be having a hazy media due to posterior capsule opacity, but you did it perfectly. Congratulations.
Thank you. Thank you.
Thank you very much, Dr. Vivek, for a lovely presentation, very crisp and precise. And
Thank you.